My name is Troy. I'm a citizen scientist researching nicotine patches. And today I'm here with Dr. Anna Sattah, or how do you pronounce your name?
Sattah?
Sattah, okay.
Yep.
She's a very experienced ICU doctor and functional medicine doctor, and she's specializing in treating long COVID patients. Can you tell us a bit about you, a little bit of background?
Yeah. So I actually started out in general surgery and I was board certified in surgery. And then I did a fellowship in critical care. And I ended up mostly just practicing critical care for 8 years. And that included all through the pandemic.
Mhm.
And during the pandemic, we had just had kids. And so I had really young children at home. And I was trying to figure out, how do I make sure if COVID is going to be infecting so many people, how do I make sure my husband and I don't get this sick, because we need to be healthy for our children. And then I was also trying to see, what can we do to try to help our patients to recover, because at the time that we were treating this in March and April of 2020, there weren't any treatments and there were no antivirals or any options. And so we're looking at, how do you support the body's own ability to heal? And the more I started looking down that realm, the more I was looking at the innate function of the immune system and how things are supposed to work naturally. I got into functional medicine, which is that same type of approach, looking at how you support the way the body functions on its own. And so I ended up training in functional medicine at the same time that I was treating patients in the ICU, with the hopes that I would figure out something that would be helpful. There's a lot that seemed to be helpful for preventing people from getting sick in the first place. I think once they got really sick and they got to us, then the ship was kind of, or the horse had sort of already gotten out of the barn, and people were in severe cytokine storm, and they were within a day or two of being on a ventilator and in renal failure and things. So that was really late to be intervening. But I also had a couple colleagues who got COVID early on in the pandemic, and they were able to get through their acute infection, but never really recovered. And this was before long COVID was recognized as a syndrome, but my colleagues weren't getting better. And because they were physicians, they were getting really extensive workups with everything we knew to test, from pulmonary function tests and echocardiograms and CT scans and MRIs. And they'd get a lot of data, but nothing that led to treatments. And so I've been focused on, how do you actually find something you can intervene on? And in 2023, I ended up switching, and so now I work full-time in functional medicine, and I still do a few shifts in the ICU, but primarily functional medicine. And full chronic illness, chronic fatigue, a lot of long COVID. And because I had the ICU experience, I just ended up attracting a lot of patients who'd had long COVID. And so that's how I got to where I am now.
You definitely have a lot of experience, and it's a very relevant experience, I think, seeing everything from every side, because you've seen everything from the ICU acute cases and from the academic world as well, and now from a holistic functional medical view of it as well. I got to know you through our Facebook group, because some of your patients are in the nicotine test Facebook group. First, I wanted to know about, like, how did you learn about the nicotine test, nicotine patches for long COVID?
That came from my patients. And when they first suggested it, it's like, well, my understanding of nicotine is as a vasoconstrictor, and I couldn't see how that would work. But I saw the paper that was just a case series with 4 patients who tried nicotine patches, and I felt like that was a pretty compelling case series. And at the time, I was running long COVID groups where we would meet with other long COVID patients to talk about some of the research, because it's not like there's an answer. Like, I don't have, this is the right answer for everyone,
Mhm.
but I think you can sit down with patients who are struggling, who don't know what to do, and I can share with them the information as I understand it. And it's almost like a journal club. And so we talked about that paper and what I felt like the risks and benefits and the potential hypothesis behind it. And I felt like it was a reasonable thing to try and relatively safe. And I have since had quite a few people try it, and every time we just go through what we saw on that paper. But with the first patient that tried it, he came back to me and he told me that that feeling of being poisoned in the morning that he used to have had gone away.
Mhm.
And that's a pretty compelling case report, just as a single experience. And so the more patients that tried it and the more patients that would come back and tell me it seemed to make a difference for them, the more convinced that I was. And yeah, and so that's how I
Mhm.
ended up with it.
Oh, okay. Wow, that's great. That's what a lot of patients are looking for, is a doctor that actually listens to them, because we spend so much time researching and everything, and we go to doctors with, oh, look at this paper. What about this? Should I take this? And most doctors just kind of say, go away. So this
Yeah.
it's always a breath of fresh air to not be gaslit and actually be listened to. Uh,
Yeah.
so thank you uh, from the point of view of other patients. So next, the protocol in that first paper was very short, only 1 week, and it was very limited at only doing 7 milligrams. The protocol that we suggest to people that is different now. But from I've talked to you before, you said that your protocol was actually also different. You've adjusted it based on your experience. So what protocol do you normally follow with your patients in general? Not as medical advice to other people, of course, but just so especially for other clinicians to know.
I think it's important to talk to a provider about this,
Mhm.
because I do have some patients who have arrhythmias or rapid heart rate or other type of symptoms with their heart rate.
Mhm.
And nicotine is a stimulant, and there is a potential that you can increase your heart rate. I've also had patients who very rapidly can, any kind of stimulant or real strong activity can cause them to crash. And so I wanted to make sure, if we're going to be starting something where, we don't really know how it's going to affect any individual. And some of my patients have become incredibly sensitive to things, and they react to things even at super low doses. I wanted to start something that was going to be the least likely to have any negative side effects. And so we started using the patch at just like 2 to 4 hours a day.
Mhm.
And then, assuming you did that and nothing bad happened, then we would bump it up by 2 hours the next day, and then bump it up by 2 hours the next day. And since nicotine's a really short, or has a very short half-life, I felt
Mhm.
like if somebody put it on and it wasn't working for them, or it wasn't the right thing for them, and they took it off, then it would wash out of their system relatively rapidly. So we did a really slow ramp up, or that was probably slower than was necessary. But I really wanted to make sure we didn't have patients crash and get worse.
Mhm.
And then we would only get it to about 12 hours. And my goal was 12 hours a day for about a week and then stop. And part of that came because in that initial paper, I think it's the third case, there was a gentleman who actually used a 15 milligram patch.
Mhm.
And he used it, he's nicotine naive, non-smoker, and took a pretty high dose nicotine patch all of a sudden. And for somebody who has no tolerance to nicotine, he basically overdosed himself on nicotine and had nausea and vomiting, and like felt terrible, and then was like, all right, I'm not doing this. And so he took the patch off, and his whole treatment was that one day, and that was it. But even after that single dose, he was continuing to improve for another week, or I think it was 8 days, that his symptoms continued to get better. So to me, that speaks to the potential mechanism of nicotine, that it is flushing off some sort of viral debris or proteins, or the S1 spike protein, or something that's stuck on the receptor. And if you can flush that off, then the receptor can reset and people can re-regulate. And that mechanism made sense. The other thing I thought was compelling about the original case reports was they were showing when the patient would use the nicotine, but then for several of them, their symptoms were continuing to improve for several days or weeks after they stopped using the drug. So something was continuing to work. And so I figured, well, we would do it for a week, and then we would stop, and we would give you like a flush out period for several weeks and see what was the end result. And then, since there's a concern about possible viral reservoir or persistent virus in the body, or something trapped in biofilms, if there really is ongoing production of spike protein or virus or whatever is continuing, then it may not be a one-time treatment. And so after we were starting to have successes with the first round, then we would see, well, what happened when patients stopped taking it? And did they maintain their gains? Did they continue to improve slowly? Did they drop rapidly afterwards? And so then we started doing it in cycles. And we would say, well, let's just try a second cycle and see what happens. And in some patients, they seemed to benefit when they stay on it. And if that's the case, then fine, stay on it. Some people seem to notice, they got a certain benefit and then didn't necessarily continue it. But I haven't had people have negative side effects. And I didn't know about the scale of your program until recently. And you actually sent me the poster that's got 148 patients in it, which I think is really impressive, because I was making clinical decisions based on a case report of 4 patients. And so it's nice to see that this is more, that a lot more people have been experiencing it. And as far as trying to figure out what's the right dose, how long do you continue it? Is it continuous or cyclic? Or I think that's still very much up in the air. And I kind of determine what the best option is when talking to patients and seeing how they respond.
Yeah. Well, that's great. It's a very good, safe approach and flexible approach. We suggest similar protocol, and that we have them build up to whatever dose they feel is their optimal dose. So they might start at 1 milligram or start at 3.5 milligrams, and then based on how they feel, they'll adjust to the nicotine. The first week is usually the worst because their body's not used to the nicotine. And there's a lot of things going on in their body. But then by the second rounds, they're pretty sure about what dose is the best for them. But that best dose is usually, for most people, it's between 3.5 and 10 milligrams. But for some people, they can't go over 1 milligram. And some people don't feel any effect whatsoever until they hit 14 or even 21 milligrams. They just don't feel anything, because I guess everybody's different on how they metabolize nicotine. So then after they've taken a break, then we just tell them, all right, based on how you feel with the patch and on the break, then you decide your own protocol going forward and experiment going forward, because there's no one set protocol afterwards. It's just, the protocol is just to help people be safe at the beginning and to not overdo it. But then from there, we don't really have a clear idea of what happens and when people need to stop. And some people think, well, they've maxed out their benefits at 2 months or something. Okay, well, I'm not benefiting anymore. So they stop it for a few days or a few weeks, and then they say, okay, I'm not going to take it anymore, or I'm going to go back on it, or I'm going to use it sometimes, or even somebody said, oh, I used the patch for 18 months, and now I'm cured and I'm off the patch and I'm back to normal life. It's like, okay, that's everybody's completely different, and it's there's not like one set protocol. I wish there were. I mean, one of the patients on the website said that he did 4 rounds of like 1 week each or 10 days each, and after that, in between, he did 1 or 2 weeks break in between the rounds, and then after
Mhm.
that, he was like, okay, I'm cured of long COVID. It's like, great. I mean, I wish it was that way for everybody. We could just say, all right, do 4 rounds and you're cured. But there's nothing, there's nothing like no set protocol that works for everybody. And of course, it's not on its own, it's not enough.
Yeah.
So since you're a functional medicine doctor and you treat your patients holistically, after they've tried nicotine, what are the other like the main steps you go through with your patients?
When I start talking with them, a lot of times I go back and see, well, what was your health like before you got COVID? Because I think there's a, if you assume 100 people get COVID and for 90 of them, it's kind of a non-event in their life. They were sick for a week and then they get over it and they're better. And for 10 of them, or 5 of them, it seems to drag on for a few months. And then there's a handful where it's several years later and they're still having really severe symptoms. To me, that's not about the COVID virus as much as it is about the way the body reacted to that virus.
Mhm,
And so I try to get a really good sense of what was going on in their life that led up to things before they got the infection.
mhm,
And for some people, they've had other fatiguing illnesses in the past, and it looks like this is just an exacerbation of what they'd had. It's
mhm,
brought out, people who have had Lyme disease in the past, it's brought that out. It'll bring out things that are in the GI tract, like people have a disruption in their gut microbiome and it makes that worse. So we look at what all was going on.
mhm,
But then as far as treatment strategies, it's based on their history.
mhm,
Nicotine to give seems to have the most rapid impact, and so I usually start with that while we're waiting to get labs back and other things back. But I think having a really good anti-inflammatory diet is very helpful.
mhm,
But that's not a great recommendation to somebody who is so fatigued and so exhausted that it's hard for them to just get out of bed and cook and go grocery shopping. And if
mhm,
you give them advice like, I want you to go on this super healthy diet and spend 2 hours a day cooking every day, well, that's just not very practical.
mhm,
Um, so we talk a lot about pacing, but I talk about it partly in the behavioral interventions, but also in the concept of mitochondrial function, because I think when people picture the mitochondria, which are what generate the cellular energy in the body,
mhm,
if you can explain that the mitochondria aren't doing what they are supposed to be doing, and this is why I need you to be pacing. It's not because I don't think you're tough enough or you need to just push through. It's because your body is running on empty. Then I think it's a little bit easier and it doesn't seem quite as dismissive to say, well, just, rest. But really, I think you do need to rest. And there's some specialty testing you can do to look at mitochondrial function. I find that helpful, but it's kind of expensive. And so it's kind of a balance. And I will talk to patients and say, well, we could just start you on a bunch of the nutrients that I know help support mitochondria. We could go and do some more objective testing to see what does that test show, and then we can be a little more precise about what we're starting. Um, the same thing's true with the gut. If we want to do more precise testing of the GI tract and the bacterial populations that are there, or do we want to just assume that they're dysregulated and try and put you on a protocol that we can go ahead and start to see if
mhm,
we can get it under better control. If people are having a lot of symptoms that seem to be related to histamine, then we'll talk about a lot of different ways to support or to decrease the histamine response in your body. We just reviewed some of the research on low-dose naltrexone, which looks to be really promising. And so we're starting to use that with patients. And that's an immunomodulator. It's a drug that's used in the hospital to reverse narcotics. So if you come in with a heroin overdose, we'll give you Narcan to reverse the heroin. But they discovered during the HIV pandemic that a lot of the patients who were drug addicts were actually doing better from an HIV standpoint than the non-drug addict patients. And a lot of them were on this drug to try to help keep them off of the narcotics. And their immune system was functioning better. And so you could go back, and they started looking at the naltrexone, and they could drop the dose to lower and lower and lower and lower amounts. And it's still working to modulate the immune system so that the white blood cells and the immune system isn't quite so trigger happy and responding to everything under the sun. And that's been used in autoimmune disease and in things like MS and ulcerative colitis and Crohn's, fibromyalgia and chronic fatigue. And so some of the clinics that are involved with chronic fatigue research, like Nancy Klimas down in Florida, she started using low-dose naltrexone in long COVID patients and has published her results. And it's not like a randomized trial, but it also looks promising. And so there have been a few studies like that. So we're using low-dose naltrexone. I think trying to do things to support the antioxidant status in a patient is helpful, because it looks like COVID kind of obliterates glutathione levels, which is your body's natural antioxidant. And so you need enough antioxidants. And if you don't have those antioxidants, you get oxidative damage, which is part of how you can damage mitochondria. So we try to support that. We also look at the blood vessels, because I think part of long COVID is related to inflammation of the endothelial lining in the blood vessels. And this affects the capillaries all the way down to the capillary level. And so if you have inflammation at the capillary level and blood's not flowing easily, and people are getting clotting, or there's concern about microclotting, I think that's all because we haven't fixed the inflammation in the lining of the blood vessels. And there's supposed to be a layer on the blood vessel wall that's called the endothelial glycocalyx, which I think of kind of like a Teflon coating, or like a slippery, slimy coating on the inside of the blood vessels that allows the blood to flow smoothly and not be like rubbing up against the lining of the walls. And that lining is very susceptible to oxidative stress and high blood sugar and high blood pressure, and all those things get dysregulated in COVID. And I think that disruption is part of the severity that we were seeing acutely in hospitalized COVID patients. Because this is not outpatient medicine, but inpatient medicine, when we were in the ICU and we were putting in large IV catheters in the neck to give people medications and sedation and stuff, you would draw their blood up into a syringe. And for some of the patients, it was just drawing up like sludge in the tube. And your blood should not look like that. Like, it should be something that's able to move and to flow. And when you would just see it sludgy in the tube, you knew that it wasn't flowing through the lungs. It wasn't flowing through the microvessels in the kidneys and like perfusing anything. And those patients would have horrendous pulmonary disease and kidney disease and go into organ failure. And we didn't have a great treatment for that. So I think getting control of the endothelial glycocalyx is important. There's a product called Arterisol, which has rhamnum sulfate in it, which is a kind of seaweed that's supposed to support that layer. And I'm not associated with that company or anything, but they were the first people that I saw who actually were looking at that layer and had something to offer to try to address that. And so I think that's an issue for some patients. And I think some of it depends on the individual patient. When you look at a person's ability to clot, there's going to be kind of variations, and some people will be more prone to clotting and some will be less prone to clotting. And I think some of that variation is going to impact how people's body responded to a virus like COVID. So we try to fix those kinds of things. We also look at just like the way the body is supposed to work as far as clearing metabolites, clearing toxins, clearing other chemicals. Given our exposure now, an awful lot of people have been exposed to a lot of different chemicals over decades, and some people clear those really fast and some people don't. And that's not, I don't know, I think that's just the natural variation. You see that when you talk to patients about coffee, and you'll have some people who can, have a half a cup of coffee at 10 o'clock in the morning and they can't sleep that night because the caffeine hasn't cleared their system yet. And you have somebody else who's has a double espresso after dinner and they sleep like a baby an hour later because their metabolism clears that caffeine really rapidly. And that's just a variation in our genetics and in the way our system works. And so if you see people and they have a lot of symptoms that suggest that maybe they aren't clearing things that well, or they've been constipated for 10 years, and if you haven't been able to clear your stools efficiently for years and years and years, then there's probably more circulating in your body than somebody who's had normal bowel movements that whole time. Those kinds of things we try to optimize. I just got back from a conference on integrative medicine and mental health that was this past weekend, and they were talking about a genetics test that's used with Dale Bredesen's protocol on reversal of cognitive decline. And it's a really precision test that looks at what are the different genetics that can show up in different people, where if you have this marker, then for you need much higher levels of B12. Or if you have this marker, you are much more prone to clotting, and we need to do the following things for clotting. Or, for some patients, they've got receptor difficulties and they don't produce BDNF as well. It's a brain-derived neurotropic factor. There's a lot of variations, but you can get that genetics, and all of it comes with, if you have this, then this is what you do about it, which has been one of the big gaps I've seen with genetics in the past, where you can get a whole huge data dump, but if someone brings to me like, a 300-page printout of all their genes, I don't know what to do with that. And so I haven't found it to be clinically very helpful. But I do think there's information there if we were smart enough to know what to do with it. And so there's a new company, not that new, but relatively new to me, where they've been using that to apply to patients with cognitive decline. And everything that I see that's being used in the cognitive decline world, which is also this like broad functional medicine approach to address everything that can lead to cognitive decline, I think those same approaches are going to be relevant for patients with long COVID, because it's a model of a complex illness. And if you can optimize everything you need to optimize for patient A, and patient B has a different set of things that they need to optimize, and patient C is another set, and we can get all that information, I think that will allow us to make more progress. And that's hard to standardize. The one thing that's been nice about nicotine is that it seems much more approachable because it's not super expensive. I've seen patients have more rapid improvement with that. And even if that gives patients like 15 or 20% of their energy back, and then it buys us some time to start going down these other avenues that will take more time to investigate, it's at least, I don't know, it's at least a little bit of a light for the patients who really haven't seen any progress in a long time. So that was a very long-winded answer. I don't know, I probably could keep talking for a long time, but
It's a complex disease. I know how you feel. Each time I talk about nicotine, then it's just, I can go on for hours and hours and hours about different research and anecdotes and variations. And well, I know how you feel.
I totally forgot. With the nicotine, I was at the IFM conference, which is the Institute of Functional Medicine, and that was back in this summer. And they had several talks on the vagus nerve and the impacts of different vagal nerve stimulators on chronic illness. And one of them, they were using a vagal nerve stimulator in patients with acute COVID in the hospital. And I think this study was in Spain. And they were actually able to get a significant decrease in some of the inflammatory markers that were such ominous markers when I was in the ICU. And this was just a little device that stimulates the vagus, which runs right along the carotid in your neck, to try to induce that relaxation response. And it's the vagus nerve and the parasympathetic system, which is the system being carried along the vagus nerve. That's the counterbalance to the fight or flight system. And so you've got a rest and digest side of your nervous system and a fight or flight side. And a lot of my long COVID patients seem to have their nervous system seems to be stuck in that fight or flight hypervigilant side of things, which makes the immune system trigger happy and people more prone to reacting to things they otherwise wouldn't have. And you can't get back into that recover side of things. And so they were talking about use of different stimulators. You can also do different breathing techniques, all of the humming and singing and chanting and deep breathing or belly breathing, all of those practices that are in so many medical traditions and religious or spiritual traditions outside of Western medicine. I think they're there because they really induce a therapeutic response that we've kind of forgotten about. And when they were talking about how this response works, and they're talking about the nicotinic acetylcholine receptor, and I just was like, wait, but my patients are responding to nicotine, and you're telling me it's the nicotinic acetylcholine receptor that's involved in this relaxation response. And it just, I think that makes sense physiologically. It makes, it fits with a clinical experience that I've seen. And so I'm just hopeful that that information can be more widely published or more widely recognized in broader circles. Because when I've talked to my conventional colleagues about it, they've never heard of it. They're interested, but they've never heard of it. So hopefully that will change.
That's one of the things that people say about nicotine. They say it's a stimulant. But the thing is that it attaches to the nicotinic receptors, which are part of the parasympathetic system. So it's a stimulant of the parasympathetic system. So it's not really a stimulant in the way that most people think about if you're at the right dose. I mean, if you have too high of a dose, then it kind of boils over into the sympathetic system. But if you're in a low dose and you're a good dose for you, then you shouldn't be having very many sympathetic effects. It should be mostly parasympathetic effects. So, and actually even helping with sleep and stuff like that.
Which is bizarre because you don't think of it for sleep. But if you can get people out of that chronic fight or flight state so that their system can re-regulate, then of course things are going to start to improve. It's just got to figure out what's the right inroads for any individual patient, because it'll vary from one patient to another.
It does. Well, that's very interesting how you made those connections through the different from different areas. So I'm always making those connections. For me, everything connects to nicotine. So I've been researching for more than a year now. So everything comes back to nicotine one way or another. One thing I wanted to ask you about is, do you ever test for glutamate levels?
I have not. I do one of the tests that I do called the NutrEval, it has some indirect markers of glutamate, but I haven't tested for it directly.
Oh, okay. We're discussing quite a bit about glutamate. It's one of the hypotheses brought by one of the researchers in our group, Kat Boniface. She actually comes to this world through TBI, a traumatic brain injury. So actually, her real life experience and her research overlap with my personal feelings of what's going on in the background, as that long COVID is kind of a type of traumatic brain injury, and it should be kind of treated as if it was a traumatic brain injury for the most part. I mean, there are other things having to do with the endothelial cells of the cardiovascular system and stuff like that. But that the core reason of why these problems linger is mostly having to do with neuroinflammation from the brain injury caused by the virus. So in the next phase of the research, which I've been working on for a long time, and I just can't get it started because you need money and support and everything. It's kind of difficult. But in the next phase, one of the things I would like to test is glutamate to see if there's different ratios. You can measure glutamate with GABA or other things and see how that ratio changes from before and after using nicotine patches and see if that correlates with patient response or not. Wondering what you thought about the idea of testing glutamate or other type of neuroinflammatory marker.
I'm pretty confident that there's neuroinflammation. And so the
Mhm.
question is, does that testing give me new information that would guide my treatment?
Mhm.
Um, and I've had some people who've responded really well on different stimulants that I think would be acting along that pathway, but it's kind of variable.
Mhm.
Um, look at neuroinflammation. Some of it is the trigger that turned the inflammation on, but I think it's also important to look at why can't you turn it off?
Yeah.
Because everyone should be able to mount an inflammatory response, and then you have to be able to shut it down.
Mhm.
And so part of shutting it down is having sufficient omega-3 downstream products. And so EPA and DHA, which are in fish oil, get converted into something called pro-resolving mediators or
Mhm.
resolvins. And those are the chemical messengers that the body uses to shut down inflammation. And from a dietary standpoint, as a population, we don't get nearly as many omega-3s as we used to, many, many decades ago. Omega oils are just much more stable, much more prevalent. They don't go rancid, they're or not very quickly, and they're in so many foods. And for fish oil, you kind of pretty much need to be eating fish, because even if you eat a lot of nuts that have omega-3s, there are a bunch of enzyme pathways that convert them downstream into the form of omega-3s that you would be getting if you ate fish. And the efficiency of those conversions is not great.
Mhm.
And from some of my training, they talked about only a 2 to 5% conversion to get all the way down to the bottom of that chain. So you'd be hard pressed to eat enough walnuts and flax seeds to get to that.
Yeah.
Um, so that's something that we measure. And we do something called an omega check, which looks at a ratio of omega-3 and omega-6 fatty acids. And
Mhm.
my goal is to get people up to 8 to 10%.
Mhm.
And unless they really eat a ton of fish, they're usually 3, maybe 4%. And it's in conventional medicine, it's used as a marker of increased risk of cardiovascular disease. But even there, I think the goal is only to have it above like 5.5 or something around that range. So we're shooting much higher. And you mentioned traumatic brain injury, and there's some good research by, I think it's Michael Lewis. He wrote When Brains Collide, and he talks about the use of fish oil and omega-3 in particular to try to help treat people who have that persistent neuroinflammation from a TBI, and that can be used as treatment, and it can also be used preventatively if you have somebody like military servicemen or people playing sports who are likely to have a concussion type injury. If they have more fatty acids on board in advance, they tend to tolerate it much better. So I would be looking at all those different ways to try to kind of shore up what your body ought to be able to do on its own. And then I assume if you have all the nutrients and everything that you need, your
Mhm.
body's going to regulate it. Then I'm going to be because it will pick up on more subtleties than I'll be able to interpret with the labs. But now I can't remember what you're.
Well, that was the for the glutamate. The hypothesis from Kat is much more complex than I'm explaining it, and she also talks about the two sides. Like maybe there's an underproduction or overproduction. I think the main problem is overproduction, but then there's also absorption from glass or something like that. And so maybe there's underabsorption or hypoabsorption of the glutamate as well. So there's those both sides that could be happening. And then I've seen like about 5 or 6 different types of responses to nicotine patches based on
Mhm.
how people respond to them. And I assume that kind of correlates to the types of long COVID and ME/CFS, and that based on the response to nicotine patch, then that even if they don't respond well to nicotine patches, that might help them with the right testing. Then know, well, in the future I need to do this and that with my diet or tests or treatments, and that would be very, very beneficial. It would be it's almost a way for people to do a kind of a test. Actually,
Mhm.
testing the nicotine patch on themselves is a way to test and see maybe what subgroup of long COVID or ME/CFS they're in. I
It's almost like a
personally,
diagnostic intervention. It's like,
yeah, it's I personally see that there are probably a lot of people with long COVID who are more similar to some people with ME/CFS than they are to
mhm.
other people with long COVID because they're in this subgroup, which actually maybe overlaps more with somebody with ME/CFS or fibromyalgia or something like this. Then maybe somebody else who has long COVID and has a different pathology
Yep.
actually going on. So, but it's all theories, not proven
Well,
yet.
I think there's definitely different expressions of it because I'll see people who have more of the like chest tightness, shortness of breath, heart, like everything in their chest just feels tight or constricted, especially with activity.
Mm.
And that seems to kind of group together. And it seems to be a little different from the patients who have POTS type symptoms and histamine reactions, and they're very sensitive to a lot of foods, and their heart rate is going up high. They get lightheaded because their blood pressure drops when they stand up. That seems to correlate with itself. And then there are people who have just profound fatigue when not when they're doing anything, but they just have no energy whatsoever. And I feel like that's more mitochondrial dysfunction. The brain fog, I think, is a little difficult because brain fog could be that you don't have the energy production in the brain, and that's why you're having trouble. I think it could be because you've got inflammation in the brain and you're not able to shut down that inflammation. And I don't know that I would be able to distinguish when somebody came in saying, I can't think clearly and I can't focus, like what of those subgroups it is. And it's probably a lot of overlap.
Well, I'm hoping that if we get enough data in the next phase, that based on their response to the nicotine patch, it will kind of be a type of biomarker um, so that people would know what subgroup they're in
Yeah.
based on their response. If they respond on the first day, or if they had a bad first week but then felt better, or if they felt horrible on the patch but then felt better after stopping, or whatever, it would kind of put them into a subgroup, and then they would know how to proceed after
Yeah.
that. So that's my dream.
Yeah.
Yeah,
And that's just a matter of having more and more numbers to look at. So
yeah, yeah. All right. Well, thank you very much for your time. It was very nice talking to you. Anything you want to add, I can put links to in the show notes of the video. What is the name of your clinic?
it's Insight Functional Health.
Mhm.
And I'm in Maryland, just outside DC in the US. And I've got some videos online that people can watch. And they're just go into some of the physiology and some things that I think are promising. But a lot of it is unknown. And I think as long as the patients and the provider are kind of okay with that and say, well, here's the level of the imperfect knowledge that we have, and do you want to try this or that? then I think it's still a reasonable approach. And there's an awful lot of things we can do. It's just a matter of how many stones you want to flip over, and honestly, how expensive are they? Because some of the testing that I think is really, it could provide a lot of information, is expensive, and it's not the kind of thing that's covered by insurance, because insurance covers things that are proven, and so much of this is not proven yet.
Yeah, that's very frustrating. Yeah. But hopefully things will change and insurance will start covering it, because they'll realize that they're saving money by getting some good data and getting people healthy faster. But
well, I've seen these types of kind of integrative, comprehensive approaches allow people to get off disability and go back to work. And that kind of intervention, I don't know, that should be worth some money in insurance. It's just that where the pots of money are divided up is different for everybody. So,
yeah. Thanks very much.
it was great to talk.